welcome everybody. Welcome everybody to this Gecko session hosted by Gecko and Gastro Foundation in association with Project ECHO from the University of New Mexico. You are all familiar with this format, and Gecko runs every other Monday at 6 p.m. I will ask those of you who have questions to put some in the chat box, but I would also appreciate if you could keep a few questions you could ask personally after the talk. Thank you. Francis, it's now your turn to start your presentation.
Yes. All right. Good evening, everybody. Thanks once again, boss, for the opportunity, and I want to welcome everyone to this session. So I'll be presenting today on diverticular diseases, including SCAD. Here we go, moderated by Dr. Fredericks. So to start with, I want to start so that we should all be at the same platform and play in terms of understanding what we're talking about. So I would like to first of all define these key terms that we'll be using from time to time. So diverticulum is a sac-like protrusion of the colonic wall. And when we say diverticular disease, we meant what clinically significant and symptomatic diverticular. And this is on the context of either bleeding or there is diverticulitis, or you have segmental colitis associated with diverticular, or what they call symptomatic uncomplicated diverticular disease. And if you look at these two images on our side, you will see you will see these two images. So the upper one is, if you look intraluminally, you will see what it looked like to have diverticulosis. And then if you look at the one below, which is this one here, you will see from the external view how it looked like for it to have a diverticulosis. In terms of how it develops, the pathophysiology, so it developed from well-defined point of weakness, and this corresponds to where the vessels, which is the vasa recta, penetrate the circular muscle layer of the colon. So if you look at these areas, these are the weak points. And typically, the diverticulum is a false one, in which, in this case, the mucosa and the submucosa hyalinate through the muscle layer, and it is only covered by the serosa. So, and this is just a typical way it appears. So if you look at this, you see that this is the muscle, but then the mucosa and the submucosa hyalinate through, and what is covering the outside is the serosa, and the muscle is not part of the hyalination. This is the typical one that we see in the colon as having a false diverticulum. As part of the pathophysiology, there has been many theories, but the key ones and the key thing that we need to remember is the fact that it is said to be due to colonic motility disorders because of exaggeration of the segment when it contracts. And then there's also the link that this is possibly due to neural issues, but then the exact mechanism is not very clear in terms of how it causes diverticular disease. There is also this that it seems to be as if it is due to high tension, and this is seen mostly the fact that it seems to occur more in the colonic, in the sigmoid colon area. So the higher the tension, then the higher the risk of developing diverticular diseases. So the sigmoid colon has the smallest diameter, and equally the segment with high pressure. So that during segmentation, because of that high pressure and the small lumen, it seems to develop the diverticular disease more. And this can be explained following the Laplace law, which simply states that the tension, the pressure is proportional to the tension and inversely proportional to the radius or the diameter. So the smaller the radius, then the higher the pressure, and then that puts more risk because of the high pressure. It tends to push against the wall, and then you now develop the diverticular disease as well. Now, there is also the issue that constipation is a major factor that seems to play out as well. So with constipation, there is increased intraluminal pressure, and then that leads to colonic mucosal hypertrophy. And with hypertrophy, the tension in the wall becomes higher, and then that leads to the hyalination through the weak point where the vessels penetrate, and then ultimately we now form the diverticulosis. And again, if you look at how it all forms, there have been so many other theories also involved that with the obstruction as well within diverticulum, there is also a change in the microbiome as well, which induces some inflammation. And with those inflammation, diverticulitis now occur in the face of diverticulosis as well. And just to say that it can occur either in the entire colon or it can just be limited to some segments. But overall, sigmoid colon is commonly involved in it. And most of the time, if you look at between right and left, the left colon is more, depending on where one came from as well. In terms of the prevalence of diverticular disease, there are various studies, and most of them seem to show that that the males are commonly affected, mostly those in the younger age group from around 40. But as you get older, it tends to flatten out between the male and female ratio. Seems to be equaling. However, in some reports, it is said that the female or the seems to have higher prevalence as you get older. So that in this graph, if you look at it, in the earlier age, between 40 and 49, men are more, but as you get to about 80, it seems to flatten out. However, some now say that women commonly overtake the men at a later stage. And if you look at the distribution of diverticular disease, like I said earlier on, that sigmoid colon is commonly affected. About 72% of the cases occur in the sigmoid colon. And if you look at the left side, so adding 10 to the 72, so most of them occur on the left side, and then transverse about 6%, and then the cecum is just about 1% of it. Now, if you look at African prevalence rate, I looked at this study. This one was done in Pretoria, and it was done by some of our colleagues over there. And I think it was published in SAMJ as well. And what they tried to do in this study was to look at the prevalence and the distribution of mostly the prevalence of the diverticular disease among Blacks. And what they found out was that out of 348 patients who had undergone colonoscopy between January and December 31st of 2015, what they found was that we had about 13.5 prevalence rates among the Blacks who underwent a colonoscopy. So this was a nice study that we have that they did at that point. It was a retrospective study, and we understood that there might be one or two dropout, but this gives us an idea on the prevalence as well. And in their study, they also noted that it is commoner more between the 7th and the 8th decade, with age range of between 46 and 86, and the mean age of being 67. They also noted that in their own study that the females have a prevalence of 57.45% in their studies as well. They look at the distribution as well in their study, and they found out that the left-sided diverticular seems to be more as well in their own study. So they look at it, those that have just only excluding the pancolonic part, it's about 61.7%. But if you have a pancolonic involving the left side, it goes up to as high as 72.34%. If you compare that to the right side, you'll see that the left side is commonly affected, which is almost the same thing as what happens globally as well. And we look at the risk factors that are involved in formation of diverticular disease. Genetics seems to play a very big role in this. I think there was a study that was done in the Scandinavian countries, and what they found out was that for twins, you have about 40 to 50% risk of going to develop diverticular disease. And also in the genomic wide studies, it has been noted about 30 loci of genes have been implicated. And among them, about 4 of them are known to predispose one to having diverticulitis. And these are the genes, the PHGR1, the FAM155A, and the CALCB, as well as S100A10 genes. And these genes are also important in cell adhesions and also in immunity and membrane transport, among others. There are other risk factors that are also involved beside the genetic part, and these include age as well. Alcohol use has been implicated, low fiber diet, NSAID and opiate, steroid, and raised BMI, and smoking has been implicated as well. And that is why, if you look at this, this seems to be like the Western life pattern. And over the years, it was initially said that diverticular disease was not common among Africans. But right now, studies are showing that it is actually common now. And I think it's because of the change in the lifestyle among Africans towards the Western pattern. Therefore, in Western life, low fiber diet with increased red meat is like a big risk factor. So earlier studies have shown that in Africa, our prevalence was as low as 4%. That was because I think our diet was more of the African type, but I think some studies are now showing that it is higher than the 4%, and it's because of the fact that we're now being tilted towards the Western pattern of diet. And also, if you look at, in terms of colonic involvement, that the right colon seems to be more involved when it comes to the the Africans and the Asian countries compared to the Western countries. So this is just a summary to look at the different interplay in terms of how it all comes, all the various contributions or the risk factors to it. So genetics, alcohol, smoking, red meat, all these play a role. And then there is also the issue of microbiota as well, changing with cytokines also being played as part of it as well. And all this seems to contribute to diverticular disease formation. So this is just a nice summary to just look at how they all interact. Like I said, and overall, what is to happen is that there is this induction of cytokines that seems to play a role, and these seem to recruit more macrophages again. They now release more cytokines, and these ones all predispose to an inflammatory process occurring. Then also there is this sprouting of nerve fibers, and that could explain the pain that some do have that almost seems to mimic the IBS pattern as well. There is also the upregulation of acetylcholine and tachykinins receptors, and the downregulation of serotonin and nitric oxide receptors as well. And all this seems to explain the symptoms that they do commonly have. Now, if you look at diverticulosis, you look at them in two arms. So you could come as asymptomatic diverticulosis, or you can come as symptomatic diverticulosis. And another symptomatic part of it, you can have diverticulitis that will further look at either it is uncomplicated or complicated, or you can have just a symptomatic uncomplicated one, or you can have the segmental colitis associated with diverticulosis. And if you look at the complicated one, you either come as a case of abscess or fistula or obstruction or even perforation as well. And that is also the arm that will just come as bleeding without diverticulitis occurring. Now, in terms of the natural history of it, so most of them will present as asymptomatic type, about 70 to 80%. and about 5 to 15 will present with bleeding, and about 4% will present with diverticulitis. And among the 4%, 85% will present as simple diverticulitis, and the 15% will present as complicated diverticulitis with either of these ones occurring. Now, I looked at Rostom. Rostom et al. Did a study. They did a systematic review to see, we are trying to analyze and see the time to events. Those who develop diverticulosis, how long does it take for them to have an event? So event could either be a diverticulitis or it could be a bleeding, depending on what the study measured at. And in these are 3 studies. And then they noted just 3 studies in 2018. And the first study focused on time to acute diverticulitis, and they found out that about 1.5 to 6 per 100 patient years develop diverticulitis, and the mean time to develop was 7.1 years. And then the second study looked at diverticular bleeding, and it was 0.46 per 1,000 patient years, and the mean time was 4.2 years as well. And the third study looked at both diverticulitis and diverticular bleeding, and they found out about 5.9 per 1,000 patient years developed either diverticulitis or bleeding, and the mean time was 5.11 years. And they also, the same study also looked at they did a Kaplan-Meier to now still assess again and see the risk of developing diverticulosis over the years. And what is significant is that if you look at this blue line, which signifies the younger age group, that the younger patient had a higher risk of developing diverticulitis, with the risk increasing per year of life. So those who are younger seem to have more based on their studies, the risk. Now, looking at diverticulitis itself, in US, about 1.9 million patients that visit the outpatient department seems to have diverticulitis, and about 208,000 of the inpatients have diverticulitis. And the incidence is about 180 per 100,000 in the US. So it seems to be relatively a common thing over there. And just to say that diverticulitis is inflammation of the diverticula and may be acute or chronic. And acute diverticulitis can be complicated or uncomplicated. And if it is complicated, then it comes as one of those things, either abscess or fistula, depending on what it presents. Again, the uncomplicated type does not have any complication. So these are the various ways that you can present in terms of uncomplicated or complicated. Again, the underlying cause for diverticulosis is either there is a micro or there is macro perforation of the diverticulum. And whether it becomes a more widespread or it is limited depends on the individual's immune system and how they interact. Previously, there was this notion that it is because of fecal obstruction of the diverticulum. However, this seems to be a very rare cause, and that no longer holds very well as such again. This time it has been postulated that it is possibly due to erosion of the diverticular wall because of the increase in intraluminal pressure, or because of inspissated food particles. So with that, inflammation and fat necrosis occur, and focal necrosis occur, resulting in a perforation. Again, if inflammation is frequently mild and a small perforation can be walled up, but if it becomes a large one, then that becomes a more major thing. Now, if the immune system is not intact, then the risk of it spreading further becomes higher. And if it is close to an organ, then it can form a fistula, or it can even lead to obstruction. And if it is not contained, then it can form abscesses, which could then be limited to either within that pelvic area, or it is just around the phlegmon in that area, or it now become a perforation with a fecal soiling and peritonitis occurring. So like I said, simple diverticulitis is about 75 to 85%, and complicated one is about 15 to 25% of the cases. And commonly, they might present with a left lower quadrant pain, there might be some element of rebound tenderness that will depict that possibly there's a positional involvement. You might have fever with leukocytosis, but these are very non-specific findings that could also make other things as well. Also look at the white cell count with the CRP. And despite that, clinical suspicion alone will give you about 40 to 65% of the cases. Therefore, if you only base on that, you might miss still quite a number of them. But if you add CT scan, you will be able to pick most of them. You can also use an ultrasound scan, but then that is operator dependent. Therefore, the risk of missing or misdiagnosis becomes higher with that. MRI can also be used, but then it is poorly specific, even though it is very, very sensitive. And then you can do X-ray mostly when you want to exclude a perforation as well in these patients. So if you look at when should I really do imaging, apart from just making that early diagnosis, there are just some few times that I think imaging becomes very relevant. So one, you do it when they want to confirm the diagnosis, either without a prior image confirming the diagnosis in the past, or you want to evaluate for a potential complications, then you need imaging. Or perhaps you maybe for those who fail to improve despite therapy, also want to image as well. And then for those who are immunocompromised, the risk of these persons presenting with more severe disease is higher, and they can have collections. So imaging becomes very, very relevant in them. And also for those that have had recurrent presentations or multiple recurrences, and you are thinking about a prophylactic surgery in them, then you also need to do the imaging to localize where the disease is in them. I did look at this HGA clinical review when you look at their management, and there were some key salient points that they raised when it comes to managing diverticulitis as well. One thing that they emphasized was that among patients with acute or complicated diverticulitis, that the risk of you progressing to complicated diverticulitis is about 5%. So there is still that chance, and one need to look more closely. Mostly if they have been admitted, then one has to monitor closely as well. Or if they presented before, we also need to keep a close watch on them. There are these risk factors that will predispose one to having or progressing to the severe or complicated diverticulitis. So for those who have the ASA score 3 or 4, which is either for those who have severe non-incapacitating disease, or for those who have an incapacitating disease, that these persons are at high risk of going to have progressed to more complicated one. Or those who have duration symptoms longer than 5 days prior to presentation, or those who have very high CRP of up to 140 with a baseline raised white cell count up to 15. And if you have the presence of a fluid collection or longer segment of inflammation on baseline CT scan, up to about 8.6 to 6.5. So they compared between these two. So those who have about 8.6 have more risk compared to those who have shorter ones, anything less than 6.5. And also they said for those who fail to respond to antibodies, so sometimes you have to consider as well. So if you see one of these factors, you need to consider putting them on antibiotics with a close monitoring, because you have the risk of going to progress to more complicated diverticulitis. So when you need to start antibiotics, you have to consider covering them with a cover gram-negative and anaerobic cover for these patients. And in the outpatient setting, and if you want to treat a mild or complicated diverticulitis, some recommend using a fluoroquinolone and metronidazole as an option. And if you want to go on monotherapy, they did recommend also amoxicillin and carbonic acid as well. In terms of duration of treatment for them, it depends on whether it is a person is immunocompromised or it is a person is immunocompetent. Commonly it's about 4 to 7 days, but for those who are immunocompromised or who have more severe phenotype, you can extend to up to 14 days of treatment. So like I alluded earlier, that immunocompromised patients are more at risk of going to develop more complicated ones. So have a very low threshold for antibiotics. In fact, it should start for those patients. Again, steroid is a risk factor for diverticulitis and may contribute to complications, including perforations and deaths in these patients. So remember that as part of your evaluation as well. They also look at the guide to preventive measures. They said to reduce the risk of recurrence, patients with a history of diverticulitis should resume a high quality diet. Just to say that high fiber diet does not mean a high quality diet. To achieve also and to maintain normal BMI as well is very important. Again, physical activity is very important, and then they should not smoke. They should avoid indiscriminate use of NSAID, preferably less than twice per week. However, for those on aspirin for cardiovascular issues, it is that they can continue with the aspirin in those patients. Now, those with history of diverticulitis should not be treated with 5-ASA according to their guideline, and that rifaximin or probiotics do not really have any good evidence for that. So they do not recommend these. Some other guidelines, I think one or two guidelines did recommend. I think the thing about the one at European guideline, I think they did mention rifaximin, but I think for HA they did not recommend that. Let's look at the role of colonoscopy as well. And one thing that is very important is that for those who are presenting with diverticulitis, mostly if they come with complicated type, you can easily miss a non-benign pathology for it because they can present almost the same way. So you should consider colonoscopy, but then you also want to avoid perforation and also avoid complications in them. Therefore, it is advised that you delay it for about 6 to 8 weeks post-presentation or when the symptoms resolve. But you should have a low threshold to do it. You can do it a bit earlier if there are alarming signs at the time of presentation. And these alarming signs include things like the stool caliber of it, and then they have a very small caliber as if it's obstructed and stool is passing through a small area. Then you have to consider, could it be constricting a non-benign pathology? Or those who are having iron deficient anemia as well, or blood in the stool, or weight loss and abdominal pain. So these are like some alarming signs that we have to consider in them. There is evidence for increased chances of cancer among those who are having complicated acute diverticulitis as compared to those who have really mild ones. So if they do have the complicated ones, you should consider colonoscopy possibly a bit earlier, or it should be something that you should do as part of your plans. And they also look at the role of surgery as well. And they say that if they have, so patients with a history of complicated diverticulitis who are successfully managed with antibiotics without surgery, there is the increased risk of recurrence in this patient as well, and even having a recurrent of complicated ones. So while some guidelines do recommend interval elective resection, there is the evidence coming on board that there is no significant difference between those who had resection and those who are managed conservatively. So there was this study that they did as well, and they found out that in terms of people who were managed conservatively presenting acutely for either a surgery, that the risk is about 5%, which is somehow low. So there is, people are now saying that, well, they have to weigh options and that people should be handled on one-on-one basis. But then they are now tilting towards conservative management as against the previous protocol of having elective surgeries in most patients. So elective resection was not associated with reduced rate of emergency surgery or death in this patient. And the same way again, they look at those who are managed conservatively, and it was also low as well. So it should be on one-on-one basis. However, immunocompromised patients should be prioritized, and the aim is to prevent recurrent and more complicated diverticulitis. I've mentioned earlier that they are at risk of developing those severe ones. Therefore, for them, you have to weigh options and see if you need to have elective resection in them to prevent more complicated cases. So this is just a flow diagram to look at how they were being, how they should be managed. And they said, yes, if they have any of the following, either fever, leukocytosis, or complicated disease on CT scan, or they are immunocompromised, comorbidities, no home support, unable to tolerate oral, then yes, we have to admit them. But otherwise, they can be managed at home, so they can be discharged on oral antibiotics, and then you just keep eye on them. They recover, then you advise them on high fiber diet, and then you plan for colonoscopy in 4 to 6 weeks time. Mostly if it is our first episode of having a scope, so also consider when was their last scope as well. And if you think otherwise, consider also a referral, mostly for those who are immunocompromised to surgery, for surgery at some point if they are assessed to have. But then if they have been admitted, then you now consider your IV antibiotics. And if you start treatment in them, you expect a recovery in 2 to 3 days. If you don't have that, then you become more concerned. If there is ongoing fever, or there is worsening pain, or there is free air under the diaphragm, or fistula obstruction, then you have to consider intervention in these persons. I'll repeat, a CT scan, and if you see abscess, then they need to be drained, or they need to have proper surgical consultation as needed. In terms of fistulas, like I said, one of the complications is fistula formation. So among patients with diverticulitis, only a few will develop complications of fistula. The most common etiology for colovesical fistula is a diverticular disease, and it's quite significant. However, cancers can also predispose to that, about 90%, and there are other conditions that can also give you fistulas, and we know our able Crohn's is one of them, among others. And for those who are having diverticular, having fistulas, surgery is the option for them. There is this tilting as well towards the laparoscopy. It used to be open surgery, but then they are also seeing that laparoscopic surgery is an option. However, there is also the high conversion rates, up to like 46.9% to open surgery for those that were earlier planned for laparoscopic intervention. And in terms of abscess as well, some of the major causes of abscess is either anastomosis, leak, or diverticular disease. So these are things that can cause abscess. And again, in terms of its limitation, it is mostly due to the person's immune status as well. So it could just be a phlegmon, or it can even progress to a very large abscess, depending on the person's immune status. So small pericolic abscess, in about 90% of cases, will respond to antibiotics. And in that case, conservative management is an option. But if you have a larger one, then you need to do a percutaneous drainage. And there was a study in Canada that looked at percutaneous drainage, and they found out that about 70% of them have a success rate. And if you combine both a drainage with antibiotics, you have a very good response of about 100%. However, there are some factors that can limit you having a success in terms of managing them conservatively. And mostly if you have a multilocular collection, or if you have abscess with enteric fistulas, or if you have abscess containing solid or semi-solid material, the risk of you getting away with conservative management becomes limited. In that case, you have to then consider surgical intervention in these patients. We also look at, if you look at the Hinchey class, I tend to categorize them as well to say this is the modified one. I think this is relevant because it also guides you in terms of your choice of management as well. So we have Hinchey 1 to 4, so 0 to 4. So 0 is just colonic wall thickening, and then if it is confined to pericolic inflammation, just a phlegmon alone is 1A. Then if we have confined pericolic abscess, that is 1B. And then if we have oval peritonitis, which is fecal peritonitis with soiling, or you have a fistula, that is 4 in this case. Now, this is important because it guides you in your management as well. And this is just the schematic diagram of what I just mentioned earlier. So this is 1A, this is 1B. And then this is the 2, and then this is 3 and 4. So this is the 4 is the one that you have a wider spread with fecal swelling and peritonitis. occurring in them. These are just still images to look at. You just so that you can have microscopic eyes to look at it, but these are just images pointing to what is just above it in terms of it as well. So what is the significance of this classification? So the guidelines do recommend your management based on what these classifications are all about as well. So if you have uncomplicated diverticulitis, which is stage 1A, yes, for that one, you can selectively treat them, either use antibiotics or not based on the person's immunocompetent status. For those who are immunocompromised, you have a low threshold for antibiotics in those cases. If you have 1B and 2, and if you have a very small collection in them, yes, and to treat them with antibiotics and cover the gram-negative and the anaerobic cover for them. But if you have 3 and 4, then you have to consider, in those cases, surgical intervention in these patients. Then you also look at bleeding as well. So bleeding, they did report about 0.5 per 1,000 persons as the prevalence for it. And the risk factors for bleeding include people who are elderly, more than 70 years of age, and for those having bilateral diverticulosis. The obesity is also linked to both diverticulitis and also with increased risk of bleeding as well. And in terms of the pathogenesis for it, so we said it is due to the segmental weakness of the vasa recta that at the point of herniation. So with those weakness, it is said that there is the unroofing of where the vessel is. So with friction, continuous friction, it seems to cause the rupture of the blood vessels, and hence the bleeding then occur. About 50 to 90% of diverticular bleed occur in the right colon. Well, we can't really see the reason why it occurs in the right colon, but it is said to be linked to the wider neck and the dome. But well, these are just postulations. We don't really have good evidence to support that. Most of them did stop spontaneously. However, there is still the increased risk of rebleeding. In terms of management, we only follow the normal protocol for them. You resuscitate them, then you endoscopic therapy as well, so you can clip it. And then for those that you have difficulty in clipping, and then you can do a CT angiogram with coiling. And if that fails, then surgery becomes the next option for them. Again, in terms of how to locate the source of bleeding, because sometimes you do your scope, they are bleeding, but you can't really locate where the source is. So the WGO guideline did give this view that indeed that about 30 to 40% of the cases, it is a bit difficult to identify the source of the bleeding. And in those cases, you can do your selective angiography. But again, even for that, you need at least 1 to 1.3 ml per minute of bleeding for you to be able to get that through as well. You can also use your radioisotope scanning. And the good thing about that is that you need a smaller volume of bleeding for you to be able to locate where it is bleeding as well. And one good thing about the radioisotope scan is that you can also do it for those who are not very stable, and for those who are on vasopressin, you can still do it on them. And then the time to repeat is also quite short as well. You can repeat it over a very shorter period of time. And the study time is also shorter as well. The accuracy of bleeding studies varies widely. And again, colonoscopy is the best reserve. It's reserved for those with self-limiting bleeding. But for those that are not limiting, then you have to consider the other options for them. And I also just want to look at SCAD as well. So SCAD is the segmental colitis associated with diverticulosis, and it's a chronic inflammatory change that do occur in the colon. Commonly, it occurs between the diverticular and leaving the diverticulum itself, so that is not involved. It is limited to the sigmoid and the left colon in most cases. Therefore, if you are seeing anyone that is involving the the rectal part of it then becomes an issue that this is possibly I am missing out something. So the ostium is commonly not affected. The rectum and the right colon are spared. And I think this becomes important even when you want to do a biopsy. You need to biopsy the rectum as well so that you'll be sure that, yes, you are dealing with a SCAD as against IBD itself, because it is one of the very big differentials when it comes to SCAD. It resembles IBD in almost in every presentation. So, but one good thing is that it seems to be a self-limiting type. So therefore, some people say that it is like IBD, but it's a self-limiting IBD in this process. In the past, they've used several terms to refer to SCAD. They were calling crescentic fold disease. They also call colitis associated with diverticular disease, and they also call diverticular colitis. So many names have been evolved over the years, but for now, what is widely accepted is the SCAD itself. This was a study that was done in the US, and they did say that in a total of about 6,200 colonoscopy performed, that the overall rate of SCAD is about 1.5 and 11%, especially for both SCAD and diverticulosis itself. The prevalence of SCAD is higher in men with a mean age of 64 years at diagnosis, although it has been reported also in the younger persons as well. But in terms of how it all occurs, it is not well known, but it appears to be multifactorial. And different hypotheses have been raised regarding this. Some will say due to prolapse leading to mucosal ischemia. Some will say due to fecal stasis within the diverticulum, with subsequently having dysbiosis, microbiota changes occurring, triggering immune response, and then with high exposure to intraluminal antigens and toxins, leading to the inflammatory process, hence the SCAD. So these are just hypothesis, but then the exact mechanism is still not well known. And again, the way it presents varies depending on the study, but one of the very common presentations is diarrhea commonly. Rectal bleeding only can also occur in some cases as well. There's sometimes abdominal pain and tenesmus. Fever and weight loss are rare. Therefore, if you are seeing these, then that will point you towards possibly IBD or something more serious. More than a third of these patients have at least 2 of these symptoms occurring at diagnosis. And if you look at the classification of it, so it's being classified from A to D. Type A is crescentic fold, and this is there is no architectural changes in the crypt in this case. Then you have neutrophil and lymphocytic infiltrate that are limited to the crypt epithelium alone on the histology. Then the type B is mild to moderate UC-like pattern. And then type C is Crohn's-like pattern. And type D is a severe UC. So the ones that commonly progress and have wider implication is mostly type B and type D. They can progress to more severe ones commonly. So the clinical picture can be very similar to that of mild IBD, and occasionally it might be asymptomatic. Again, the way they present depends on whether it is type A or it is type B. Somehow, some of the symptoms are linked to various types as well. And it is said that diarrhea is more common in type A, and while rectal bleeding and pain is more common in type C and type D. They said type B presents with more than one symptoms, but in 39% of the time, with diarrhea and rectal bleeding being the main ones that it present commonly. To diagnose SCAD, again, like I said earlier on, that it commonly is a great mimicker of other things, and then so you need to exclude those other conditions that can look like SCAD itself. So ischemic colitis is one you need to exclude. Then also need to exclude drugs as well, mostly NSAID, then infections, and of course, our big IBD, we need to exclude that. And for us to make a diagnosis, colonoscopy is what we can't avoid. When you do your colonoscopy, one thing that is very important is that you need to biopsy the rectal areas. And that is because you want to be sure that that area is not involved. Once you have a sparing of the rectal area, it is more reassuring. This is likely scarred. It's strengthening the diagnosis. It is also said that you need to discuss this with the pathology itself to give a clear history, to be able to make a better assessment of the biopsy specimen. And so this is just a diagram, a picture that tends to represent. If you look at this A, this is diverticulitis, and you can see that between them it is paired, but then just at the ostium alone is what is involved. Whereas in this one, the scarred, you can see inflammatory changes between the diverticular, but if you look in the diverticulum, they are spared, they are not involved. The ostium is quite clean. And this one with the florid inflammation is the IBD friend, which is more of the UC in this case. So in the treatment of scarred, because each phenotype looks very much like IBD, somehow the treatment also seems to follow about the trend of IBD as well. So it can be managed in the case of a mild IBD form. It is considered to be more benign than IBD itself, and many a times they do resolve spontaneously. Type A and type C seems to show a milder evolution as compared to B and D, which is the UC like, and then the more severe UC like. So we say that type C is the one that looks like a Crohn type, but then the B and the D are the one that look like UC. So they are the ones that seems to have a more aggressive phenotype, and I need to follow them up closely. So in terms of treatment of scarred, well, it is still not well defined as such per se. It is said that high fiber diet is helpful, and there is also the place for the use of antibiotics as well. And ciprofloxacin and metronidazole are the drugs of choice that can be used mostly in those milder ones. And if that fails, then our mesalamines can be used mostly if there is some satisfactory response to antibiotics, or if you're having recurrent symptoms, then you can use your mesalamines. And if that fails as well, then you now move to the third line, which is the use of steroid in more severe cases. There is also recent evidence supporting the use of beclomethasone, dipropionate as well, for 4 weeks, concurrently with a VSL tray. That this seems to give a very good response as well. And there are also studies showing the use of biologics that people also respond very well as well for those that seem to have those aggressive phenotype. And this one is just a summary of the treatment options available using the Cipro and the Metro, and then the mesalamine group, and then you now come to line 2 using your steroid as well, or maintenance with mesalamine, and then you now come to prednisone. And I think before the surgery, there is now the option of possibly the use of biologics, and this was published in the Annals of Gastroenterology as well. I think I will, and this is my last slide. Thank you so much.
Thank you, Francis. The talk is now open for questions. We would welcome a few questions, please. We have time for a few questions. Francis, while we are waiting, let me just pose this to you. If you have a patient that is known with diverticular disease, and on endoscopy and now present with severe bleeding to the point that they require blood transfusion, what would your line of investigations be? How would you start investigating this?
Well, if they present to me, so it's in two ways. If they are coming with severe bleeding at presentation, then I will manage them first with the basic things to resuscitate this patient, and then I think I have a low threshold for consulting with the surgical group. But if they are coming with just the anemia, with a background history of diverticular disease, then I will have to then take a different route in terms of how I investigate them. Again, I will still start with I will do the upper scope as well to see, because other things can also give you the anemia as well. So I'll still do upper scopes, and I will still do a colonoscopy in them. Like I said earlier on, that yes, there could be other makers like non-benign pathologies. So if I do, and if I don't see anything in these ones, here again, if I see a point of bleeding, but I don't seem to locate where it's bleeding from, then I would then consider using the images for that as well. But again, I'll still do a CT scan as well, just to be sure that there's nothing that I'm missing out.
Yeah. So that's my question really was about imaging, and what imaging would you use? What would you, on your request form, what will you ask for?
I think what I'll if there is bleeding at that point, I'll do an angiogram, CT angio, because I want to locate the bleeding site for those patients if there is a bleeding at the point of presentation.
So that's the message that we want to bring is just an ordinary CT will not help in this instance. It may tell you something you already know, but what you want to know, you want to locate the source of the bleeding if you want to do interventions.
Yeah.
So colonoscopy in this instance, so if you identify it in the left colon, it's from a sigmoid, when would you do colonoscopy in this instance? The patient required blood transfusion, by the way.
So if they require blood transfusion at the time of presentation and there is active bleeding, then I'll do the CT angiogram. I think again, before I do the CT angiogram, I think I'll still do a colonoscopy first. I'll do the scope to see if the bleeding is something that I can control. Then I'll be able to manage them as well intra procedure. Then I'll do the colonoscopy. But if, so I think I'll do it when they present, depending on how the bleeding is, if it's a severe or less severe. But if it's what I can handle right there, and then I'll be able to do it right there and there.
Okay, Francis, there is a question here that says there are a few trials, this is from Cecilia, that showed no benefit of antibiotics for mild diverticulitis. What is your take on this?
Yes, so there, like I said, there are different schools of thought, and there are different guidelines as well. There are some that says that you don't need antibiotics. There are some that says, yes, you have a low threshold. But I think what is most important is that you deal with each patient as they come. For those who are immunocompetent, you can do without antibiotics. But for those who are immunocompromised, they said you should have a low threshold for antibiotics in those patients. But yes, you can do away without antibiotics in those mild cases, but put the patient in context. And mostly for those who are immunocompromised, have a low threshold for antibiotics.
Francis, specifically patients that have uncomplicated disease but present regularly to the emergency department with acute diverticulitis, what will be the timing for surgery? How will you time surgery electively in these patients? What are the things that drive surgery?
Again, the guideline did mention this, that, and I think I will follow that if they are presenting with recurrent ones, I also look at the immune status, because for those who have uncomplicated diverticulitis, there is still the risk of progressing to complicated one in about 5% of cases. So I have to look at the context. What is the immune status of the patient? If the person is immunocompromised, it is advised that you should have a lower threshold for elective surgery. But then if it is immunocompetent, it is said that you can manage them conservatively, because if assessed to see that even though for those who are that are managed conservatively and those who have elective surgery, that there is no significant difference in terms of long-term presentation with more severe phenotypes. So when to have surgery, again, is individual, is patient-based. And I think I'm not very averse to having surgery as such per se. I would rather go the conservative path first, except that is immunocompromised patient, then I would then tilt towards more of the surgical part of it.
Okay, everybody happy with that answer? I think we're running out of time. It is 7 o'clock, so I just want to say thank you to Francis for the time and effort he took to do this comprehensive presentation. And I hope everybody has learned something today. And I also want to thank the ECHO from the University of New Mexico and ECHO India team for their support during this presentation. And feedback from this talk will be available in the chat, and recordings will also be available on the Gastro Foundation website if you want to go again and have a look at this. And finally, I just want to say thank you to Francis and thank you to everyone who tuned in to listen. I think it was quite informative. Thank you. And the next presentation is on the 3rd of October by Joseph Adebie, and he will talk on microscopic colitis, ischemic colitis, and divergent colitis. It's quite a mouthful. And that's on the 3rd of October. Thank you, everyone. Bye now.
Thanks.